If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Medicine in America, hosted by Anthony Manson and Todd Harrington, shares the stories of physicians, other healthcare professionals, and industry leaders who are changing the way we deliver care. There's an episode that you should check out called Primary Care Reimagined with Subscription-Based Preventative Care Model. It's an inspiring call for a paradigm shift in primary care. All of their episodes highlight innovative ideas at the forefront of the movement to transform our healthcare system. Check out Medicine in America on your favorite podcast platform or visit healthpodcastnetwork.com.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Welcome back to Healthcare for Humans. I'm your host, Dr. Sundar. In our previous episode, we heard from Nazreen and Sarita about language use, specifically in immigrant, refugee, and migrant communities. Today, we continue our language series with a two-part conversation featuring Dr. Marie Liebel, founder of Health Communication Partners. Health Communication Partners works to improve patient relationships and employee retention through more equitable communication. Emphasis mine, because I hear a lot about communication and health literacy, but not enough focus on what equitable communication means. She's doing this by providing research-driven resources and services as a mixed methods researcher and lifelong educator. As a physician, I constantly reflect on the role of communication in my practice. Recently, I had somewhat of an eye-opening experience with a patient, I'll say. It was about blood pressure. He came in because he had high blood pressure, he was worried about it, and we decided to start him on a medication. I, of course, assumed that he would be taking it for a while, long-term. But he returned just after a few months and said, I took it for 30 days and felt better, so I stopped after that. His response made sense when considered from a cultural perspective, at least for him, from his origin of country. He was saying that he typically went in when he felt ill, usually got a medication, and when he felt better, he stopped taking the medication. It made sense to him. And this experience highlighted that the real challenge for me wasn't about the diagnosis or treatment plan often, but rather about effective communication. It taught me the importance of understanding someone else's worldview. We talk about that a lot, but particularly to craft the right language and ask the right questions while challenging my own assumptions about what needs to be conveyed. So it is the words we choose to communicate, and it is also what are we choosing to communicate at all. For this patient that I just talked about, I had to talk about the definition of chronic illnesses, and that's what I was diagnosing him with. And I didn't even call attention to it because I was starting from my own perspective. The interaction highlighted the need to tailor my communication style to each patient's background and perspective. So then we can have a shared understanding of diagnosis, treatment plan, and of course, long-term management goals. In this two-part series with Dr. Marie Liebel, we'll dive deeper into the concept of communication generally in healthcare. Building upon the insights from our previous episode, we'll explore the power of language across different communities. Here's what you can expect from this episode. Dr. Liebel's journey from education to healthcare and the unique insights she brings to the field because of this journey. The role of reflective practice in improving communication and building stronger patient relationships. Practical strategies for recognizing and building upon the strengths and resources that patients bring to the table. As you listen, I encourage you to reflect on your own communication experiences and challenges. Stay tuned for part 2 of our conversation with Dr. Marie Liebel, where we'll dive even deeper into practical strategies and real-world examples of equitable communication in healthcare. Without further ado, let's dive into part 1 of our conversation with Dr. Liebel. Welcome to the show. And
thanks so much for having me. This is a treat. I've been looking forward to it.
I've been really excited to talk to you today because so much of my work is evolving into is communication in ways that we let down our patients, in ways that clinicians feel frustrated because our systems doesn't allow space for the communication that they want to see happen, or they don't have the knowledge or skills. Let's start out with a little bit about your story on how you came into healthcare, because that's not where you were trained.
It wasn't. Thanks. Yeah, I am from the education world, and I started as a classroom teacher for about 10 years, and then I was a professor for about a dozen years on top of that. And it was when I was professoring that I got pulled into a research project on patient-physician communication. And I thought, what am I doing here? And then it really grabbed me when I started getting into the research and I started seeing, wow, there is an awful lot we know from the education world that could be helpful here. And it wouldn't let me go. And I thought this is the best possible use of my degree that I could imagine. Getting to serve the same kids, the same families, the same communities that I did as an educator, but helping the people who are on the front lines doing the work.
Yeah, I've said this to you every time I talk to you because I realize how healthcare feels so insular because we look to our own field for answers. And it's such an innovation or novel approach to look outside of healthcare to see what other research is out there in different fields.
But it's happening. Like, I have watched that snowball pick up speed, like coming down the mountain. I watched it in the 10 years I've been in the health sector. And I remember in 2000, I guess when it was like 16 or 17, when an ER physician said to me, "We figured someone must know more about this than we do." It felt like a revolution. And now I think there's a lot of willingness. Like the NIH says, the future of health is interdisciplinary. There is a lot of busting out of the silos. So I'm here for it. It's interdisciplinary work. It's multi-sector work. It's difficult. And we've got to really have our wits about us, especially when it comes to research.
Yeah. Let's start with this question. Tell me what shocked you once you got into healthcare. What did you see, witness, and realize?
Oh, I love this question because I can remember some of my colleagues' office that I was in. I'm in South Carolina and I was a professor at Clemson University and I was at this office at Clemson and it's starting to dawn on me. I'm hearing these conversations and I'm going home and reading the research and coming back to these conversations and holy cow, you have such difficult jobs in medicine and in public health. Your full-time job is not my full-time job, but you still have to care about what I do as my full-time job. So I felt like this sense of urgency. Let's get some of what I know, the knowledge base that I'm coming from could be helpful there and get it there as quickly as possible, which is why I started a podcast series because it's quick. And so that was really what grabbed me and what it let me go is when I saw the passion, when I saw the absolute commitment, when people really wanted to say, oh my gosh, about literacy, come and talk to us. About education, come and talk to us. And that train just hasn't stopped.
Yeah. And you've been an educator, educating clinicians, I feel like, for some time now. And I want to talk about health literacy and shared decision-making today. I want to talk about how we fail in both of those concepts with our patients and how I see it fail. There's definitely pockets of excellence of people who do it well. How should we enter this conversation as we're going to challenge some ways that we approach it? And what context do we need to know?
That's great because my public health friends had told me when I was in grad school, they're like, hey, there's this health literacy thing. You should check it out. That literature, it's been on my radar for about 15 years now, but obviously it's been front and center for the last 10 years. And I come at it from a particular angle because of the space, the research traditions I come from in literacy. So I'm reading the field of health literacy as someone in literacy and in a very specific critical space in literacy. So even though we have the term literacy in common, there's definitely a lot of overlap, especially in our aims and our concerns. And I think I'm excited about health literacy the last 4 or 5 years because there's been a big push to see organizations as entities that you could say have health literacy. And before that, there was a lot of just focus on the patient as an individual, focus on patient skills or lack thereof, and to the new definition that came out a couple years ago, says, okay, we also need to look at organizations as structures that are full of words. And those words need to also be considering the patient side of it.
Yeah. And people listening to this episode know we love screenings in healthcare. We love to screen you for things all the time. If you're a patient or healthcare provider, we love giving you forms. We love screening you for social determinants of health. You probably heard that term. And one aspect of that, not universal, but sometimes people put in health literacy. Try to assess if a person's health literate. And this talks to your point of being individual. I see somebody, I'm going to assess if they're literate in their health. Assumption being, this question is going to tell me if they understand enough about health to take care of themselves. So there's automatically a power differential and a power analysis that's happening there because I'm the expert on health. You're probably not. And if you're from a different culture, you probably haven't prioritized enough because actually disproportionately we label people from different cultures as health illiterate, even if they're in the United States. And then we try to go from that starting point. That feels wrong to me. Does that feel wrong to you?
Yeah, thanks for putting it that way, Raj. The starting place of a lot of health literacy work, not all of it, and it's definitely trying to shift, as I've been watching it too. The starting place of health literacy being, we're going to screen you and you're going to do badly. Like we're almost, the starting place of, now we've got to change it because of you. We did have this kind of language, but now because you're going to not do well on this and we're going to assume you're not going to do well on this, now we got to change it. That's already inviting a whole lot of feelings about a patient that we don't want because it gets in the way of the relationship. It gets in the way of trust. And it also has a narrow view of what counts, but this is not unique to health literacy. This is the health literacy field by and large. Even when we're talking about kids in classroom, we like giving them tests about and showing, oh, look how badly they're doing and look how badly this subgroup is doing. And now we're going to run in there with all this remediation stuff. What we don't get to ask is, well, what are they saying? What are they reading? How are they using language? How are they taking good care of themselves? It really does keep us away from asking those kinds of questions.
I think the language that I was reading was it focuses on the deficit perspective rather than the strength of the patient. I'm wondering is there a strength-based approach to this that acknowledging that people have an intuitive sense of health and our goal isn't to show them they don't and teach them. At the same time, you're balancing this fact of, hey, I got trained in medical school and I've been doing this for a while and you did come to me for a reason. Navigating those aspects can feel difficult for folks because you can then say, we're not saying you know everything about health overall, but you do know some things, right?
Let me start with the deficit perspective. That's something that I get asked about a lot and I talk about a lot. And so just to let people know, a deficit perspective is when you have this singular focus on what someone lacks, situation lacks, or what their culture lacks, what they don't do, what they don't know, what they don't understand. They're negative depictions, negative examples, and that's where the focus stays. Like, obviously, people have needs. Obviously, people have deficits. But it's when we let that completely drive the bus and we forget that people also have resources that we can start talking down to folks. We can start missing them. We can start telling them things that they didn't need to hear and not telling them things that they did need to hear. So to flip it, as you asked about a resource perspective, absolutely. And a short way that I ask people to remember that is like, everyone has linguistic resources. And what I mean by that is everyone is an expert language user. One of the ways that we can think about equity and language, because that's what I bring equity lenses and to communication. And people are like, what does that mean? Does it mean you use the right pronouns? Yeah. Does it mean you don't use discriminatory terms? Yeah. Does it mean you got to watch out for microaggressions? Yeah. And there's a lot more than that. One of the ways that we could think about a resource perspective is people are already doing things to take care of themselves. People are already doing the best they can to try to be healthy, to try to help themselves and their families. So rather than going in with the feeling that people are not doing the thing that you want them to do. Just try in yourself to imagine that they are already on their way to doing the thing you want them to do. I'll give you an example because this can be a little bit abstract. I was talking to a wound care clinician who said a really common question that they tell patients, don't forget to get out of your chair 2 to 3 minutes a day. And that's assuming that they're not getting out of their chair. And it's not even a question anyhow. So when we talked about that, she said, oh, what I could do is say, how often do you get out of your chair? The assumption being that they do get out of their chair or that they do know that they're supposed to get out of their chair. And maybe they just need a little nudge to remember, oh yeah. So it's a different assumption. It's a different starting place. Whereas a lot of screenings can lead us to start on the place of lack and the place of what they don't know or don't do. A resource perspective invites us to say, what do they have? We all have cultural and linguistic resources. What are they already doing to take care of themselves? What ways are they using language? What are they reading? What are they viewing? Who are they following on social media?
Yeah, that's a good example because there's also a message of hope in there. Because I feel clinicians feel they're powerless in big systems to make change. And how a single sentence and phrasing of that sentence can make a difference. Don't get me wrong, it's not going to solve everything. But in that moment, in that relationship, that patient felt differently because you assumed they're coming from a place of strength than deficit. And that interaction over time, if everybody approaches them that way, can build up their identity and help them take ownership or feel empowered about their health.
Thanks for that, because I think this is one thing that if I'm at a conference with somebody and we're having lunch and I've got 2 minutes to talk to them and they want to know something, oh, well, what can I do? This is a lot of times my best piece of advice. Don't assume that people are not doing the thing that you are trying to help them do, but that they are either doing it or they're on their way to doing it, just from a deficit perspective or a resource perspective. But I also want to say here, I don't think anyone's setting out to be in a deficit perspective. I think this has a lot to do with the systems that we inherited. And when it comes to health communication in particular, the way that health communication has evolved as a field. Like, I am not a historian of the field. However, I have talked to some people who are, and it almost seems as if health communication had to find a way of working alongside medicine that played well with the way medicine sees the world. And so that led us down a certain path using certain tools, certain orientations, and a physician speaking at an NIH conference said it best, I think, just before COVID. Like, we can't study people and human interactions the same way we study brain cells. And that definitely has opened up some permission for people to go ahead outside of medicine and look and see, what can we do? What are some complementary knowledge bases out there that would help us enrich what we're already doing in the communication space?
I agree. I think medicine suffers from thinking that we're very technical, meaning the answers to the problems that we face with disease and illness is a technical problem. And we study through randomized controlled trials solutions for that, then we implement those solutions. And there's some importance in thinking outside of that framework on what helps people heal, because it's not just about that technical treatment of disease.
And I agree with you completely. And everyone I've talked to for more than 5 minutes, I think knows that. There is a sense that there was something missing. Like when we were talking about communication research, there's questions that we have. I remember someone coming to me in a conference and being like, okay, so we can't capture what we're seeing in our data. Like, our current frameworks are not capturing that. We have analyses that we're doing, and it's just not capturing what we know is there. So the reaching out for additional tools is real. And I see people doing that very thoughtfully and very carefully and systematically, which is what I think we need to do. To piggyback off what you're saying, one of the inherited ways of looking at communication that people are stepping away from and are finding alternatives to is really centering the clinician in the research. And I think it's very important to study what the clinician says, because you're talking about very complicated topics. And so studying what a clinician says is obviously very important. I think the whole reason that health literacy as a field exists is because people were like, we're leaving patients out of the equation entirely, the patient side of this. Because people kept saying, oh, it's the other side of the equation. And I was like, what are you talking about? And it took me a while to see, oh, it's because the field had been dominated by the focus on the clinician, which is understandable. But now let's focus on the patient as well. And I think that is a good sign of this kind of complexifying and elaborating of what has typically counted as communication research with more tools, with more options.
I want to encompass this conversation that we're having and frame it in a metaphor. I know you're an expert. That's how I first found your name. A patient, let's say a 60-year-old Khmer woman comes to me in my clinic. She has joint pain. I look at the joint, hear her, listen to her story, and want to diagnose her with gout. In this relationship, am I an educator, a consultant, the physician, a provider? Which word or metaphor encompasses my role the best? And it could be a combination of multiple of these roles. I'm framing it that way because, say, I'm a provider. There's a lot of reactions people get with that. Hey, we're not at Target. She's not coming to me to get a prescription. I'm just here to make her happy. Different context that lands with people differently.
Yeah.
A physician that has a paternalistic history for that, I tell you what's right and what you need to do. Consultant gives more power to the patients that they can decline our recommendation without us saying they're non-compliant or placing a label on them.
The question that you're asking me reminds me of a lot of the questions that when people come to me, they're asking, and they tend to fall into a couple categories. And one is, how do I deal with this particular kind of patient? And the approach that I come from, it's not just an equity approach on communication, it's an equity approach on learning. And it's heavy on reflective practice. And sometimes I explain it like this. Medicine does get that it's been paternalistic, as you said, in its model that is openly talked about now. And there has been this shift to shared decision making. But the paternalism is in the communication deeply. It is hard baked in there. So before we say, oh, okay, here's what you can do next, we got to look at what you're already doing. And in the story that you just told me, some of what I'm hearing is the expectation that there is one right way to do that. And for instance, going back to the metaphor, I had a clinician talking with me about metaphors, and he goes, oh, we should go and find out what metaphors have been tested and approved. And I was like, you absolutely can do that. And if they're tested and approved, you got to find out where they're tested and approved for. Like, where did they do this testing? Who did they do it on? So definitely go ahead and look at that research, but you got to look at it a little bit critically, because if it worked for a certain group of people in a certain place, that does not mean it's going to work for your patients where you are. So that opens up the question of research on our own practice as communicators and as educators. And that is also part of what I bring to party that I help folks with, is being researchers of their own language use so that they can create locally relevant options and locally relevant knowledge. What I'm listening for in your story is also the traditions that you have come from that are saying, Raj, there is an answer for this and you had better go find it. Like the validated metaphor. There is an answer and you had better go find it. When we realize that, yes, there is this global set of knowledge that we need, there's also a local set of knowledge that we need, it can also give us a little bit of power back, because we have the power to research our own practice. We have the power to generate local knowledge. And I find that something that people appreciate hearing about, and I'm very excited to teach them about, because it is claiming back power that has been lost through some deprofessionalization over the years.
I love when you challenge my whole question.
I want to be in there in that room with you, with that patient, and see what's going on.
Yeah.
Because you are thinking interdisciplinary. You are thinking about, what hat do I wear right now? And is it possible for me to wear multiple hats at the same time? The answer to that is yes. And if you wear this hat, if you are fronting this identity right now, how does that go with the patient? What did you notice in them? Because the research tradition I come from, in communication, we research actual language use. So what people actually say spontaneously in real life instead of like hypothetical language.
Thanks again, everyone, for joining me on another episode of Healthcare for Humans. If you liked this episode, as always, my ask to you is please share it with one other person and go to healthcareforhumans.org to sign up to be part of the community. I'll see you next time.
If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Medicine in America, hosted by Anthony Manson and Todd Harrington, shares the stories of physicians, other healthcare professionals, and industry leaders who are changing the way we deliver care. There's an episode that you should check out called Primary Care Reimagined with Subscription-Based Preventative Care Model. It's an inspiring call for a paradigm shift in primary care. All of their episodes highlight innovative ideas at the forefront of the movement to transform our healthcare system. Check out Medicine in America on your favorite podcast platform or visit healthpodcastnetwork.com.